many others. Dr. John?
Yeah, I mean, ma'am, journal clubs is part of our, I mean, it's been part of our, curriculum for, since I was a resident here in FMC. We do it every Thursday, and it's almost sacrosanct that we do discuss journal clubs, but it does not happen as, on a routine basis in the other armed forces teaching hospitals in, say, Bangalore, Delhi, Mumbai, I mean, wherever our armed forces hospitals are. But FMC, it's a regular schedule. And we do also we encourage our residents to write letter to editors. I mean, that used to happen earlier, but now, you most often are able to submit only an e-response, but even that's good enough. And interestingly, whatever you have written as a letter to editor or as an electronic response, it stays on their website. For example, if it's an archives of diseases article, it stays as a response. So, I mean, if you Google it at some point of time in 10 years henceforth, you might actually find your response there, though it's not counted as a publication. But I think it's still pretty good to see responses to the various journal articles. I think we can go ahead now.
Now, Sanjay.
Yeah, so I welcome all of the esteemed faculty as well as the attendees for this first, let us say, version of the journal club. This is a new activity totally. We have never done this before, and the pandemic has been a blessing in one way, because I don't think we would have done it in a physical way. Probably not. So we would not have had too many attendees, but I see almost around 50 attendees already. So that's great. So this online journal club is a new experiment which we want to do. I, as a pediatrician who practices as well as works in an academic institute, have two outlooks towards it. Number one, as is being discussed, to get new knowledge, updated knowledge, which has been scientifically proven in a good way. In the sense, if you look at journal articles, there are several medical reps who come to you कि journal में article पढ़ा है हमारे drug के बारे में देखो. And if you look at the articles which they give you, they are absolutely useless. So at least we should be able to understand what is a good article. If someone gives us some article, कि उसमें कुछ दम है क्या, ऐसा ही कुछ छाप के लाया है. I think as a practicing pediatrician, we should be able to cross-examine him. कि क्या लिखा है आपको पता भी क्या है उसमें. इतना तो कम से कम हमको वो article से समझना चाहिए. That is what I feel. And of course, updating our knowledge is very important. So getting new information from the journals, from good quality journals, good quality papers, is very important, not only for the PGs, but also for the pediatricians. So I look at it as one important activity which can be used by the PGs as well as by the practicing pediatricians to enhance their knowledge and to get to know which are the good standard papers. So let us hope that we can go towards this in some way through this journal club. Hopefully, we'll be having one journal club per month. That is the plan. And I will fail in my duties if I do not mention Dr. Otiu Madam as a special mention, because it's a relentless efforts which have kept this PG program running regularly. And this journal club is also, we have discussed it since the beginning of the year to have this journal club. So she has been very particular in getting this thing started. So a very big thank you to Otiu ma'am. And with this short introduction, I request Dr. Nupur to begin the journal club. I think the pattern has already been told by Otiu madam. She will be presenting the journal, and whenever we feel that the experts feel that some things need to be clarified or discussed, they can please interrupt so that the things can be discussed. Please, Dr. Nupur.
Okay, thank you, sir. May I share now, sir?
Please.
Is it visible, sir?
It is, yeah.
Yes.
Okay. Good afternoon to the esteemed panel. Thank you very much for giving me this opportunity to present the first article in this journal club for an activity which hopefully will continue for more time. The article in review today is a study published by Cochrane et al. In the New England Journal of Medicine in 2018, the clinical trial of fluid infusion rates for pediatric diabetic ketoacidosis. So what was the research question for this study? The authors questioned what was the effect of specific intravenous fluid regimens, such as fast 0.9 NS correction, slow 0.9 NS correction, fast 0.45 NS correction, and slow 0.45 NS correction on neurological outcomes during treatment, as well as on a 16-week follow-up in children with diabetic ketoacidosis. So coming to what's this study about? Children between 0 to 18 years who have been diagnosed with diabetic ketoacidosis were randomized to 4 different intervention groups. As mentioned before, these were fast and slow 0.9 and 0.45 NS correction. And the outcome was measured in terms of GCS and memory tests during treatment, and on follow-up in terms of memory as well as IQ. What was the background for the study, as in why did they think about this? So clinically apparent brain injuries are seen in almost 0.5 to 0.9% of episodes of DK. They generally manifest as sudden neurological decline, which is associated with increased morbidity and mortality. However, in some cases, without overt manifestations, we may see subtle neurological alterations, which are often seen after recovery, including deficits in memory, attention, and IQ. So the studies mentioned in the slide were the ones which were cited to say that neurological injuries are reported in children with DK. However, the authors of this paper have also questioned whether these studies were robust enough, whether there is clinical equipoise, and if yes, is the evolution of this neurological injury in any way related to fluid therapy? So going through some evidence quickly, this prospective study was carried out in Melbourne in children aged 6 to 18 years who were newly diagnosed with type 1 diabetes. MRI and MR spectroscopy was done at different time points, and MRI alterations were compared with clinical parameters, after which the authors concluded that diabetic ketoacidosis at diagnosis resulted in morphological and functional brain changes. This next study, performed in the US, found that patients with diabetic ketoacidosis were found to have poorer verbal IQ. In this other study, among a cohort of children with type 1 diabetes, the authors found that those with history of DK had disrupted spatial and color memory. Whereas in this study published in 2015, children with type 1 diabetes and DK were compared to their non-diabetic siblings and were found to perform poorly on a spatial delayed response task. Coming to white matter microstructural integrity, in the study in Missouri, patients of type 1 diabetes again were compared with their healthy siblings, and the authors found that the superior parietal lobule, the hippocampus, as well as the thalamus were vulnerable to changes secondary to hyperglycemia. Whereas this study in Washington concluded that decay at presentation was associated with lower mean diffusivity throughout white matter. So what was the cause of this neurological injury? So initial research established that this DKA-related brain injury may be secondary to rapid administration of IV fluids, which decreased serum osmolality and resulted in brain swelling. The evidence for this, if we see these studies, this one was performed in Wisconsin, in which the authors said that faster the rate of fluid administration, sooner was the herniation. Whereas in this study, the authors recommended that if you give fluid over a longer period of time, this will prevent rapid decline in serum osmolality and will protect against herniation as well as near death. However, one very important point is that these studies were subject to bias, as firstly, they had patients who were more dehydrated and therefore received larger volumes of fluid. And secondly, they also had patients who had been referred to them because of severity of illness, and before referral had not really received protocolized fluids, that is, treatment protocols, which were specifically used at pediatric centers, were not followed. So in fact, some new evidence has shown that the rates of clinically apparent brain injury have remained stable over time, and properly controlled retrospective studies have not shown any association between fluid administration rate and brain injury. For example, this multi-center study, which was published in the New England Journal of Medicine in 2001, looked at 61 children who had DK and found that of all the therapeutic variables, only treatment with bicarbonate was associated with cerebral edema, and that some had cerebral edema even before initiation of treatment. This other study, which was a case control study performed in Canada, showed that patients who had cerebral edema were more likely to have a greater degree of dehydration, acidosis, uremia, and hyperglycemia at presentation. Whereas this study, performed in Parkville, Australia, looked at over cases over 20 years from 1973 to 1992, and basically found that the incidence of cerebral edema stayed constant in 2 time periods. So they divided it from 1973 to 1982, and then from 1983 to 1992, and found that the incidence stayed the same, and it stayed constant irrespective of the difference in the rehydration fluid in the time periods, as well as in the rate of fluid administration in the time periods. So instead, new evidence suggests that brain injury may result from abnormalities in cerebral perfusion and inflammation that occur during episodes of decay. For example, in this study, they found that there were elevated serum endothelial activation markers in mice which had decay as compared to controls. After going over all this evidence, let's go to the current trial. So in this trial, the authors have investigated the effects of specific intravenous fluid regimens on neurological outcomes in children with diabetic ketoacidosis. The detailed methodology of this trial was published 5 years before, that is in September 2013. Going over this trial quickly, it was a large multi-centric trial. 13 emergency departments in the Pediatric Emergency Care Applied Research Network, which spread all over urban centers in the US, were involved. And they used a 2x2 factorial design to compare 4 rehydration treatment regimens, that is fast rate and slow rate. And in the fast, again, you had 0.9 and 0.45 NS. Again, for slow, you had 0.9 and 0.45 NS.
So sorry,
this was called
can,
the 2x2.
Can I stop you for a minute?
Yes, sir. Yes, sir. Should I stop sharing, sir?
No, it's okay.
Okay.
I think you have done a good job of looking at the references which were given at the initial argument of the study as to why this study was planned. And those initial studies of Fergus Cameron and other people that you just showed, so they had many limitations, as you pointed out. So before we go on with the reading this paper, as a reader of the initial introduction and the references given, what is your, I can't say conclusion, but what is your understanding so far as where was the deficiency in knowledge? What was the knowledge gap because of which this paper was planned? Because unless there is a knowledge gap, there is no point in doing a study. So what is the knowledge gap here?
I think, sir, basically why this was brought into question was as that study was done in Australia, which showed that the incidence of cerebral edema stayed constant in 2 time periods despite different fluids and different regimens. So maybe that was what made them question.
If you read through all the previous trials, you realize that irrespective of whatever doctors have done over the last 30, 40 years, remember it started with Milwaukee protocol for decay.
Yes.
After Milwaukee, there have been about 4 or 5 modifications of this protocol. Interestingly, irrespective of what you do, the prevalence or incidence of complications hasn't changed much. So no matter how erratic and useless doctors are, human bodies can actually cope with whatever you do to the patient. But the rate of complication doesn't change drastically.
Yes.
So irrespective of the different protocols used, as you mentioned, the outcomes that were not changing much. So they wondered whether there is something very different before you start the treatment that leads to these neurological changes. That's the primary question. That is it your treatment that decides, or is it what happens to the patient before the treatment begins that seems to dictate the outcome? That is the knowledge gap, right? It's a bit like cerebral palsy.
Yes.
I mean, pediatricians and gynecologists around the world have worked so hard to reduce the prevalence of this condition, but I don't think much had changed when it comes to incidence of cerebral palsy. So it's something that happens before we come into play. And this is what this article is trying to address. That is it your treatment regime that determine, or is it something else? If your treatment regimes are going to determine, you will find a significant difference in the 4 therapeutic options that you just mentioned. That is the knowledge gap. Right? So it's very important before you go on to read a paper. After you read the introduction, you must have this question in mind. Okay, now I understand this is the knowledge gap. Let me see, can this article first hypothesizes this? That's number 1. So I'm sure you're going to tell us the hypothesis behind this paper, and then you will move on to the standard procedures such as methods and statistical analysis, etc., etc. So thank you. So please carry on.
So Dr. Nupur, if I may add, to simplify this, you could have said there is a pattern called as and, but, therefore. So and means the pre-existing knowledge. Okay, so we already know this thing, but means this is the knowledge gap, and therefore gives a reason for doing the trial. So this is called as and, but, therefore. This is a standard kind of pattern that is followed. So that will make it easier for the person who is presenting the journal club.
Thank you so much. So should I go over the research question again?
No, it's okay. Please carry on. Please carry on.
Okay. So this study was carried out over 13 emergency departments in the Pediatric Emergency Care Applied Research Network over urban centers in the US. They used a 2x2 factorial design to compare 4 rehydration treatment regimens, which in children with diabetic ketoacidosis. Now, this was called a 2x2 factorial design because there are 2 independent variables. They are looking at a fast rate and a slow rate, each of which has 2 levels. Again, you have 0.45 and 0.9 NS as the fluid content in each level. This allows the researchers to examine the main effects of 2 or more individual and independent variables simultaneously. So a quick look at what is PECAN. So PECAN is the Pediatric Emergency Care Applied Research Network. It is the first federally funded multi-institutional network for research in pediatric emergency medicine in the United States. So a quick oversight over the trial. It was designed by the first and last authors with input from site investigators. Collaboration was performed by the PECAN Data Coordinating Center and its subcommittee. The data collection was performed by research coordinators under the supervision of the site investigators. Quality control and analysis was performed by the coordinating center. The data and the safety monitoring board oversaw the conduct of the trial, appointed experts in various specialties, convened before enrollment, and performed interim efficacy analysis at the time of 4 additional scheduled reviews of safety, enrollment, and follow-up data. So the authors of the study vouch for the accuracy, completeness of data, as well as the analysis and fidelity of the trial to the protocol. There was no industry funding, and the sponsor as well as the authors had full access to the data belonging to the institutes. Coming to the methodology of the study. So the inclusion criteria included children between 0 to 18 years of age who had received a diagnosis of DKA, which was defined as a blood glucose level of more than 300 milligrams per deciliter and either a venous pH of less than 7.25 or a serum bicarb of less than 15 millimoles per liter. There were some key exclusion criteria. So they excluded children who had underlying disorders that could affect mental status testing as well as neurocognitive evaluation. Children who had concurrent alcohol or narcotics use, head trauma, other conditions that could affect CNS function, patient who had already received substantial treatment for DKA prior to arrival, known pregnancy, or factors for which the treating physicians determined that a specific fluid and electrolyte therapy was necessary. And children who presented with a GCS score of 11 or lower were also excluded because they believed that the fluid therapy for these sick children should not be left to randomization. Coming to the treatments part, before starting the treatment, written informed consent was obtained from parents or guardians, and assent was obtained from kids who met the minimum age for assent. And then children were randomly assigned to one of 4 treatment regimens, as we've seen before. Randomization was stratified and in blocks according to the baseline GCS, which was either 14 or 15 or less than 14, and center-wise. and this ensured that there was similar number of patients in each study arm. Children who suffered a second episode of diabetic ketoacidosis during the trial were also eligible to undergo randomization again a second time, but no more than twice. So this is a very busy slide. So I'd like to take
Dr.
you through it
Nupur,
step by step.
if I may
Yes.
interrupt slightly, I just want you to
Yes.
tell us whether you are happy with the ethical issues as well as the inclusion exclusion criteria. Do you feel that they leave any scope for bias?
Yes, sir, because in the exclusion criteria, they have excluded children who with DK who had a GCS of less than 11, which is something we see in severe DK. So they have included mild to moderate DK in their this thing. And plus, sir, I was not very convinced about how they have randomized. For example, how they have chosen which child will go to which group, whether the fast group or the slow group. And was there any criteria? Does this child deserve to be in the fast group? Will this child deserve to be in the slow group? So if it was really randomization, there may have been some, the fluid may have not gone that well for a child who required it and may have been, you get it, sir.
How do you know that some degree of bias in that way may have been in randomization may have been created? But that is, if you look at the baseline characteristics, was there any difference in the baseline characteristics shown in the 4 groups?
No, sir. No,
there
sir.
was none.
From
There
what
was
they
no.
have said,
There was no. But
yeah,
I just want to ask whether there was some issue of bias introduced in the selection criteria, because some part was left to the physicians about whether to include a child or to give special fluid regimen. That is why they would not be included in trial. So would that introduce any bias?
Sir. Yes, sir, definitely. Because when we go through.
Okay.
Yes, ma'am.
Okay.
I think inclusion and exclusion criteria were well decided right at the onset. So if you just Nupur, go back to that slide of inclusion and exclusion.
Yes, ma'am.
Keep projecting. Don't because every time it takes longer time.
Correct.
So just project that slide. What Dr. Vijay is asking us, that was that appropriate or it was inappropriate? So what they excluded was that the underlying disorder which could affect so this actually is a potential for confounder and narcotic use and all. Again, it's a potential for confounder because these things can also affect the neurology, head trauma. So obviously, I think these are the well-deserved criteria for exclusion.
Yeah, I agree. I think inclusion exclusion are very well designed actually, because whenever you get GCS score of 11 or lower, the on-site intensivist is going to make deviation from the protocol, and when that happens, the patient should be excluded from the trial. I think they're pretty well designed.
Yes.
Right.
Can I say something? Nupur, you said like you were not sure how the randomization was done. Did you dig some more details about how randomization was done, since it was a multicentric trial? Because I would tell you.
1 second. Yes, sir. Sorry.
Did you get my question?
No, sir. Could you repeat it, please?
See, you said there was some issue with randomization. You are not very clear. There is a risk of bias while they are randomizing. So did you get any more details as to how did they randomize, since this was a multicentric trial involving 13 centers?
Yes, sir.
Did you dig into any deeper details? Do you know where to look?
No, sir. No, sir. From there was stratified random, that I understand, sir. But my question initially was, before I read the tables, of course, that could they really randomize children without looking at their clinical characteristics? But later in the table that they have shown, they do mention that the clinical characteristics of all the children across the 4 study arms was the same. Like laboratory values and all of them were the same.
That is a separate issue. But when they made sure that everybody had an equal chance of getting the intervention, right? That is the whole purpose of randomization. And I'm sure this would have been the very fact that the paper has been accepted in NEJM. This was a central randomization, computer generated, without leaving for bias. And if you would have looked at, there is a supplementary file which always gets published.
Yes, the supplementary.
The supplement, all this would have been, and the statistical analysis plan, this would have been described in great detail. So always these methods which are described in the article, they are only like 10% of the work that the authors have actually done. The remaining 90% would be there in the supplemental files, where you would find the answer.
You know, look at that methodology article that has been published in 2013 mentions all these things, and it was a properly randomized single blind trial. The parents, the patients did not know what they were receiving, while the clinicians knew it. I think you will go
only
to
the clinicians.
Yeah.
Yes.
And Dr. Nupur.
Yes, sir.
If I may actually just in between, if you allow me, show one slide of when you have such kind of covariates, what is the method of randomization? I'll just show you one slide. If you let me share the screen, I'll just show that one slide. I hope you can see this slide.
Yes, sir.
So I won't project it on a projector mode, but just have a look at this, because this is precisely what your study is all about. See, your sample size is what? That's the first question you ask. Then if your sample size is less than 200, which is small to moderate, then you ask yourself this question. Are there covariates that need to be controlled? And in your study, there are covariates, of course. And they can be controlled because you have got 4 treatment regimes. So the answer is yes. Are the participants enrolled in the study continuously or all at a time? So you also gave a second chance to people to enroll. So continuously. So you go straight away to the last box, covariate adaptive randomization, which is what was done in this study. So this is a very useful diagram for people who actually do studies, and maybe later on I can share this with you. So I'll stop sharing my screen. Please go ahead.
Yes. So can I continue with the treatment regimens?
Yes, please carry on.
Thank you, sir. So this is, at first glance, this is a very busy slide. So I'll take you through it step by step. So as mentioned earlier, there were 4 treatment regimens, irrespective of the, so there were 4 treatment regimens. We have fast administration of 0.45, fast administration of 0.9, slow administration of 0.45, and slow administration of 0.9 sodium chloride. Now, irrespective of the group they were randomized to, all of the children received a 10 ml per kilo bolus, initial fluid bolus of 0.9% sodium chloride. The children in the fast group were assumed to have a fluid deficit of almost 10% of body weight, and this deficit was replaced over 36 hours. So during the initial hours, they replaced half the fluid deficit and continued maintenance fluid. Then the remaining half of the fluid deficit was replaced over 24 hours and maintenance fluids were continued. It goes without saying that those in the 0.45 NS group received 0.45 sodium chloride solution for replacement of deficit, while those in the 0.9 received 0.9 sodium chloride. Those in the slow group, the fluid deficit was assumed to be 5% of body weight, and the deficit as well as the maintenance fluids were evenly replaced over a period of 48 hours. And again, 0.45 and 0.9 NS were used as replacement fluid as per the group. The children in the fast treatment regimen received an additional intravenous fluid bolus of 10 ml per kilo of 0.9% NS. So apart from the fluid treatment, the usual treatment for diabetic ketoacidosis was followed. That is the insulin treatment. IV infusion was started at 0.1 units per kg per hour. Dextrose was added when the serum glucose level fell below 300. Patients and their parents or guardians were unaware of the treatment group assignments, but the clinicians were aware because they needed to know the fluid protocol for clinical decision making. So this was basically a single blinded trial in which the participant is not aware, but the physician knows what treatment the participant has to receive. What were the outcomes of this trial? So the primary outcome was a decline in neurological status, which was evidenced as how the Glasgow Coma Scale score fell below 14 during the first 24 hours. Whereas the secondary outcomes, we analyzed them, it was analyzed during treatment as well as 2 to 6 months post-decay, that is at follow-up. So during treatment, we looked at short-term memory, which was evidenced by forward and backward digit span recall with score ranging from 0 to 60, as well as the appearance of clinically apparent brain injury, which was a deterioration in mental status needing hyperosmolar therapy, endotracheal intubation, and death. At follow-up, we looked at short-term as well as contextual memory in terms of spatial tasks as well as color tasks. IQ in the form of, and IQ, all of these were checked in the form of digit span as well as forward and backward digit recall. The validity of clinically apparent brain injury, or the definition, was reviewed by independent expert committee, and this committee was also unaware of the treatment group assignments. Coming to the assessments, so after enrollment, the Glasgow Coma Scale scoring was done early, and in children above 3 years, the digit span tests were done at enrollment and at 4 hours. This continued for 24 hours or until resolution of decay, which was defined as transition to subcutaneous insulin if the decay resolved before the 24-hour time point. Now, assessment at follow-up, so of memory, function, and IQ, this was performed at follow-up after 2 to 4 months, and maximum up to 6 months, the patients were allowed to come back. The prerequisite was that during assessment, the child should not be in a state of hypoglycemia or ketosis. For children above 6 years, to assess IQ, they use the Wechsler's abbreviated scale of intelligence. And for children between 3 to 6 years, they use the preschool and primary scale of intelligence. They also measured the digit span text. They looked at contextual memory with color and spatial position tasks, and shorter and simpler versions of these same tasks were used for children less than 5 years. Assessors of these neurological things were blind to original fluid regime. So should I continue?
Yeah, Dr. Nupur, I just wanted to find out what was actually the hypothesis with the objectives.
1 second, sir.
No, you can continue with the slides,
yes,
not
sir?
a problem. You can continue with the slides, but I just wanted to tell me what was the basic hypothesis of this particular study and what were the objectives stated, and then would come the outcomes. So,
okay.
Nupur, you can tell the aims of the study that you started off with.
Yes, sir. So, ma'am, so the aim of this study was basically to see whether the fluid rate and the fluid content affected the evolution of neurological injury in a child with DKA. So that was what we had planned to assess. So we assessed, so the paper assessed that during the DKA itself, as well as on follow-up.
Okay. So I think the protocol, if you look at the protocol closely, the protocol says that it is the hypoperfusion of the brain. The hypothesis, there are 3 hypotheses which they have given, and they talked about the hypoperfusion of the brain and the duration of it would be responsible for, and reperfusion injury, which also is dependent on the duration of the hypoperfusion, which is important. The first 2 caveats, and third one I would say is whether giving hypertonic, the higher sodium content and a faster fluid would be more helpful. So that is what the hypothesis is. So that on that basis, they have based this particular study.
I think, Vijay, the hypothesis can be stated as follows: whether you give this, I mean, there is you can call it null hypothesis, whether you give 0.45 or 0.9, whether you give slow or fast, the outcome is not different. So that would be the hypothesis, prove or disprove.
Okay, but the only thing is we
because they are not talking about the perfusion of the brain. All that they are talking about the deterioration in sensory. Whether the perfusion,
which is not clear from the topic is whether they are assessing equivalence or superiority or non-inferiority. I was not able to understand or get it from any of the particular.
No mentioned that they want to look for the cerebral perfusion, because this is not the study is about the clinical outcomes, which is deterioration in sensorium or memory, IQ, etc. at the age of between 2 and 4 months after the child had episode of decay, something like that.
Yeah, I agree with Dr. Madhu, because I think they have kept the hypothesis very simple. And because it is a simple hypothesis, it is relatively easy to prove or disprove. Otherwise, if you include so many things such as cerebral perfusion, etc., there is no method or way described in the entire article to prove or disprove any of those that you just mentioned, Vijay.
No,
So,
they were mentioned in which they have given on the site.
No,
they have given the
agreed. But if you read through the article, I mean, an article when gets written, unless there is data that is shown as results to support the primary hypothesis, nobody is going to even look at your paper. So the hypothesis they have kept is very simple and straightforward.
Right. Okay.
Please, Dr. Nupur, carry on.
Yes.
Nupur, don't stop sharing your slides, please.
Yes. In terms of statistical analysis, so we had primary analysis which was performed on the basis of the intention to treat principle, and it did not include those who on enrollment or on admission had a Glasgow Coma scale score of less than 14, as these children had already met the primary outcome. So quick review at the intention to treat analysis. It basically analyzes all randomized subjects in their assigned groups, utilizing as much information from each as possible, and adherence to intervention is not necessary. Now, the secondary analysis included the per protocol analysis, that is the patients who had adhered to the intervention, as well as the safety population, that is the participants who took the experimental treatment even when they were assigned control treatment. So for the primary analysis, the sample size was almost 1,360 children out of 1,389 who had a baseline GCS of 14 or 15. The overall type 1 error rate for the subgroup analysis, or the which was in secondary analysis, was preserved at 0.05. So the data was analyzed with the use of non-parametric tests, which are generally used when the distribution of the data is skewed. So two tests were used. The Cochrane, Mantle, Heinzel tests were used. My understanding about these tests was that this test is basically ideal for a 2x2 factorial design. And it was used to test the effects of the rate of administration and of the sodium chloride content of the fluid, as well as to look at the incidence of clinically apparent brain injury. The Van Eldren test.
Dr.
Yes,
Nupur,
sir.
for the understanding of people who are listening and who may not be well versed with the methods of statistics, can you explain what is type 1 and type 2 errors in hypothesis testing?
Yes, sir. So, sir, if we assume that the null hypothesis is true, that is, so 1 second. Can I just please stop sharing, because is this okay?
Yeah, sure. Yeah.
Hello?
Yeah.
So 1 second, I'm having a little problem in the network.
Okay, while she is getting back to the network, let me guys tell you that type 1 and type 2 errors in hypothesis testing are like this. That type 1 error is when the rejection of a true null hypothesis when it is actually true. So it is also called as false positive findings or conclusion. So, or in other simple English, if I have to tell you what is a type 1 error, an innocent person gets convicted is a type 1 error. Okay.
Yes.
Whereas a type 2 error is when you fail to reject the null hypothesis when it is actually false. Or in simple English, it is either called false negative or a guilty person who does not get convicted. That is type 2 error. So simply remember this. Type 1 error is an innocent person is convicted, and type 2 error is a guilty person does not get convicted. So these errors can come up in your statistical analysis. So they are called as type 1 and type 2 errors. Right, carry on, please.
Yes, sir. I'm sorry, my network is...
Not a problem.
So should I start with this slide again, sir?
Yes. From here you can take on.
Yeah. Okay. So non-parametric tests were used to analyze these results. The first of which was the Cochrane, Mantle, Heinzel tests. So my understanding of this test is that it is ideal for a 2x2 factorial design. So it was used to test the effects of the rate of administration and of the sodium chloride content of the fluid, as well as to look at the incidence of clinically apparent brain injury.
It's a non-parametric test of 2x2 analysis.
Yes,
so 2x2 in the sense you have two independent variables and two dependent variables. And your independent variables in this paper are, your dependent variables in this paper are changing. That's why you have to use this test. This is the only test that can actually fit the bill.
Okay.
And I hope that for the understanding of the people, PGs who are listening, can you please explain the parametric and non-parametric data? You have drawn some nice diagrams on that slide. That's why I'm encouraging you to do that.
Yes, sir. Okay. So, sir, parametric data is barometric tests are used for symmetric distribution. That is basically when your mean, median, and mode all lie on the same line, and that there is equal distribution of data on both sides.
Yes.
So is that? Yeah.
So it's not skewed. It's not skewed to either left or right.
Yeah.
So when your data gets skewed, you have to use a non-parametric test. So when your data doesn't conform to the bell-shaped curve, and your kurtosis is wide and your skew is to one side or the other, you use non-parametric test. So for example, height is a parametric variable. It has a beautiful bell-shaped curve, whereas weight is a non-parametric variable, always skewed to the right. Remember these simple examples. Right.
Yes.
Please carry on.
The next test that was used was the Van Elteren test. Sir, I've not really understood how this test works. A simple understanding what I had was that amongst stratified data, it creates ranks amongst the stratified data itself. And that this test was used to understand the magnitude of the decline in the GCS as well as the duration in which the GCS was less than 14. And we adjusted stratification variables for the same.
I think that is good enough understanding, because see, some of these statistical tests which have been actually recently developed, you have very specific uses of these tests. And many of these, if you look at this test original paper, it's pretty new. It's not like your parametric and non-parametric like Mann-Whitney test. So I think that's fair enough understanding. The important thing to understand in reading a paper is, see, you and I are not statisticians. We should have a fair background understanding of the statistics, and we should be able to understand whether the right test is applied. You may not know all the details about the test. You are not expected to know. But as long as you know that your data is parametric and non-parametric test is applied, you may be all right. Because non-parametric test would give the same result to a parametric data, but the reverse cannot be done. You can't apply a parametric test to a non-parametric data. See, that type of a basic understanding you must have. I don't expect you to know details of any of these tests for that matter, but as long as, see, now with Google in your hand, you can see whether this test is applied to the right kind of data. That's all you need to know. So I think that's fine. You just move on.
Regression models were used to analyze treatment interactions, and a linear mixed effects model was used to analyze the digit span scores. And the digit span score was taken as 0 if the GCS was less than 14. Two-sided O'Brien-Fleming stopping boundaries were used for interim efficacy analysis. Overall, what I have concluded is that strong or robust statistical methods were used for designing and analyzing the study.
Agreed. Now see, with the linear mixed models, what are now, because these people are using R more than SPSS, and in R you have all these modules. The gamless model in R can do this analysis so much better than SPSS can. So many people are using these linear mixed models far more effectively than in the past. And we do see more and more use of this done in the papers now. But that is the better method. There's no doubt about that. So carry on.
Yeah. So over a study period of 5 years, really, from February 2011 to September 2016, 1,255 children were randomly assigned to one of the 4 treatment regimens. So 132 of these children underwent a second episode and hence were randomized again, whereas inadvertently 2 of them who had had a third episode were randomized as well. So we reached a total of 1,389 episodes of diabetic ketoacidosis. The demographic and clinical characteristics of children, including status with respect to the history of diabetes, whether they had a past history or no, did not differ significantly among the 4 groups. The adherence to the assigned treatment regimens was excellent and enrollment varied among the emergency departments. One center enrolled 23, while another center went up to 239 patients. So this is just a quick look at the CONSORT flow diagram. CONSORT stands for Consolidated Standards of Reporting Trials, and it encompasses various initiatives which have been developed by this group to alleviate problems which are arising from inadequate reporting of these trials. And it is endorsed by prominent general medical journals as well as leading editorial organizations. So let's go over this flow diagram in detail. So initially 4,912 patients met the inclusion criteria, which was age between 0 to 18 years and a diagnosis of DK, of which 2,064 were ineligible due to various reasons. Out of the 2,848 which were eligible, 631 were not approached. Out of the 2,217 that were approached, 812 had a guardian who did not give consent. And out of the 1,405 who did consent, 16 did not undergo randomization, giving us a total of 1,389 DK episodes after randomization was done. Now, these 1,389 were divided across 4 treatment regimens pretty uniformly. Most of them received an odd 350 patients, of which in totality, almost 28 patients had a GCS of less than 14 and hence were not included in the primary analysis. They were included in the secondary analysis. So this is just a table that shows us that the demographic and clinical characteristics of the trial population were same across the 4 treatment groups. So shall I continue?
Yes, please. Yep.
So during the course of the trial, the GCS declined to 14 in almost 48 episodes. Of these 48 episodes, 22 resulted in children receiving hyperosmolar therapy, while in 12 episodes, the children had clinically apparent brain injuries. So this 12 comes to a percentage of almost 0.9%, which was similar to previously documented frequencies. Most of the 12 patients who had clinically apparent brain injury presented with severe acidosis and hypocapnia, and 1 out of those 12 died, while the others recovered without any neurodeficit. So as we can see in this table, there were no significant differences among the groups in those episodes in which the GCS declined to below 14. However, incidence of clinically apparent brain injury was slightly higher in the slower rehydration group as compared to the fast rehydration group, but the differences were not significant. Digit span scores during the episodes of DK did not differ significantly, but the rate of improvement was slightly more favorable in the rapid rehydration group. No differences in adverse events were seen across the 4 treatment regimens, except for 1 death that occurred in the fast 0.45 NS rehydration group. Now, in subgroups defined according to age as well as history of decay among patients with Glasgow Coma scale of 14, no differential treatment effects were seen. However, in those with severe decay, which was defined as a pH or PCO2 in the highest quartile and in the lowest quartile, and BUN and glucose in the highest quartile, the number of episodes in which the GCS declined to below 14 and the number of episodes in which clinically apparent brain injury was confirmed also did not differ significantly. Then we had a subgroup which was defined according to the PCO2 level, and therefore faster improvement was seen in forward digit span scores, and this faster improvement was observed in the faster rehydration group as compared to the slow rehydration group. Similarly, in subgroups that were defined according to the pH, in those with low pH levels, fast improvement in the backward digit span scores was observed in the faster rehydration groups as well as the slower rehydration groups. So out of 1,287 episodes in children more than 3 years, these were the ones who met criteria for neurocognitive testing, which means that they did not have hypoglycemia or ketosis at assessment. But of these, 30.1% almost were lost to follow-up. And so data was analyzed for only 855 of these children. And there were no significant differences in neurocognitive outcomes after recovery among the trial groups. Similarly, digit span scores were also assessed. But when we calculated how many children they were assessed in, we found out that the follow-up was basically ranging from 57 to 64%. However, they were similar across all the 4 treatment groups. So should I continue to the per protocol
What follow-up would you consider good? What is a good follow-up?
Sir, at least 90% or all of them should have at least come back for a follow-up. 57 to 64.
Yeah. Anything more than 80% is considered decent.
Yes. Yes, sir. Can I continue, sir?
Yes,
Yeah.
yes, please. Yeah.
Yeah. Okay. So now coming to the per protocol analysis. Now in 8.3% of cases, that is almost 115 episodes, the fluid regimen differed from the set protocol. There were protocol deviations. So what they did was these were excluded and the analysis was repeated. And the authors reached the ultimate conclusion that there was no significant differences in the decline in GCS or in clinically apparent brain injury. Coming to the per protocol analysis post recovery, that is seen on follow-up, again, there were no significant differences
Nupur,
in the
I
decline
have a
in
question. Nupur, I have a question for you. What is the exact difference between intention to treat and per protocol analysis?
So, ma'am, in intention to treat analysis, you are taking into account all the children who you have randomized, irrespective of whether they have followed the protocolized regimen or not. Whereas in per protocol, we are analyzing only those children who have received treatment as per the set protocol.
So which one is better?
Sir,
which one is better, intention to treat or per protocol analysis?
Sir, I feel intention to treat would be better in terms of understanding how your randomization has worked.
Well, that has been the yes. Per protocol, because you see what
per protocol will tell you the treatment.
You're right. Like we need to know what is the protocol deviation. If the protocol deviation is going to be more than 5% or maybe 10%, then like you will take the results with a pinch of salt. That means that there is a lot of contamination in the way the trial has been conducted.
Yes, sir.
So what was the protocol deviation here? What was the percent?
So 8.3%, sir.
So within the acceptable limits?
I'm sorry, sir?
Was it within the acceptable limits or outside the acceptable limits?
So it was less than 10%.
I don't think we know.
I'm sorry?
Sorry, same, Madhu. Sorry, I didn't hear. Yeah, it was within the acceptable limits.
I think we do not know whether it was in. I don't know whether it was in acceptable limits or not. I'm unaware of it actually. And here I just want to make one point. Intention to treat analysis is done to somehow, to some extent, mitigate the bias, you know. And so once you randomize, you analyze them. While per protocol is those who have strictly followed the protocol. And if there is a vast difference between intention to treat and per protocol, then you have to ask very difficult question or uncomfortable question to the investigators, is my understanding. Anybody else?
Generally, the intention to treat analysis would be giving you a conservative estimate of the effect. So it tends to doesn't give you the overestimate. It just underplays the effect slightly more compared to the per protocol analysis. Whereas in inferiority studies and equivalence studies, they would believe more with the per protocol analysis.
But it is something like a sensitivity analysis that is being done, because then certain variables which you want to exclude and analyze, and if you are getting the same results that you would get in an intention to treat analysis, then obviously your results are robust.
Correct.
Absolutely, that's what they have done.
Yeah,
correct.
Yeah, and just to talk in statistical terms, is intention to treat analysis is a method for analyzing a prospective randomized study where all participants who get randomized are included in the statistical analysis and analyzed according to the group that they were originally assigned to, regardless of what treatment they receive. That is intention to treat. But as Sachin rightly said, there will be some protocol deviations because of this. And this method allows the investigator to draw accurate, which are unbiased conclusions regarding the effectiveness of an intervention. And actually, the statisticians believe that this method preserves the benefit of randomization. But I think Sachin raised a very important point here, that the percentage of protocol deviation, and I'm also not aware, Sachin, exactly what is the percentage that is allowed or is acceptable.
It is, like I take your point, it is not allowed, but most of the trials, they would specify that they would accept a protocol deviation of around 5% or 10% when writing your protocol. And per protocol, there is the deviation is within the acceptable limits, people would take it, especially for a study like this, where some protocol deviations are going to happen.
Very true.
This is a difficult study to conduct in real life scenario.
It's a very difficult and a very vast study, actually, very vast study.
Vast study, yeah.
Dr. Nupur, just for the understanding of people who have just entered PG or wanting to write theses, that p-value, that magic p-values that you have put up, can you just tell us a little bit more about what is significant and what is not?
So from my understanding, sir, p-value is the probability of us getting a false positive.
No, just for the sake of numbers, see, 90% of our people who write their theses get their statistical analysis done by somebody else. Now, when they get a number, and these p-values are like this, as you have put up on this slide, from 0.18 to 0.67. What is this? Which one will be considered as significant and which one as highly significant?
Sir, as far as I can see from these, none of them will be considered, because I think p-value is basically how many of...
See, what Karikar sir is asking him, less than what is significant is what he is asking.
0.05 we generally take it as, ma'am.
And less than what is highly significant?
Highly significant.
0.01. 0.01 is highly significant. 0.05 is significant for all practical purposes. Because for that 0.05 is, you have 95% confidence limit and 5% confidence limit, and 99% is just 1% left out. So 0.05 is significant. 0.01 is highly significant, because people need to know there are lots of p-values which are coming up, and people won't understand why Dr. Nupur is saying that this is not significant, because none of them are actually falling in that category.
Yes, sir.
Okay. Please carry on.
Yes. So, coming to the results among the patients who have received protocolized fluids, so continuous versions of the fluid administration rate as well as the fluid content were modeled in the regression analysis, and various covariates were also included, which would reflect the severity of decay, that is the levels of pH, PCO2, glucose, sodium, BUN, the age of the patient, as well as the past history of diabetes, whether it was new onset or pre-existing, because all of these would influence the clinical presentation as well as the decisions. So all of these were also included in the analysis. However, no significant effects were found of either fluid administration rate or fluid content on the CNS outcomes. But this data, they've not really shown specifically in this paper. So even if you go to the non-neurological adverse events, we see that hyperchloremic acidosis was most commonly seen, or rather was seen in a larger proportion in the groups that received 0.9 NaCl as compared to the 0.45 group, and was more commonly seen in the group that received fluids at a faster rehydration rate as compared to the slower rehydration rate. The 0.9 NS group also had an increased incidence of hypocalcemia and hypophosphatemia, whereas the rapid rehydration group had only an increased incidence of hypocalcemia. Hypoglycemia and hypokalemia were observed at similar rates in both. However, there is no mention of the data regarding hyponatremia, which is such a crucial component of various theories regarding evolution of cerebral edema and decay. And the time to resolution as well as the duration of hospitalization was same across all 4 treatment regimens. So should I continue to the discussion?
See, Nupur, I have one question again. Are you going to do a critical appraisal at the end of the article or?
Yes, sir, at the end of the article.
Okay. Then we will ask questions that time.
Yeah.
Yes. So going towards the discussion, what are the conclusions that the authors have drawn from this study? So they found no significant differences in decline in mental status or in the rate of clinically apparent brain injury during treatment or in neurocognitive function after recovery from DKA on follow-up among patients who had received different rehydration regimes. However, in certain findings, rapid rehydration groups had the lowest rates of mental status decline and clinically apparent brain injury, but the p-value for this was non-significant. Also, there was faster improvement in digit span recall in the rapid rehydration groups, the p-value for which was significant. These findings underscore the lack of a causal association between rapid fluid administration and DKA-related brain injury. So how can we explain the deterioration in the GCS? So there are new studies, recent studies, which suggest alternative hypotheses. First of which includes that cerebral hypoperfusion or reperfusion with neuroinflammation are central to the DKA brain injury. And fatal brain injury occurs basically before even the initiation of treatment. And edema may be a consequence rather than the cause of the brain injury. So this study looked at apparent diffusion coefficient values during treatment in 14 patients and found that there were elevated apparent diffusion coefficient values during treatment, which suggested that there was a vasogenic process that was ongoing during diabetic ketoacidosis. At the same time, this study was carried out in 50 juvenile rats using magnetic resonance spectroscopy, and they concluded that cerebral metabolism is thoroughly compromised during diabetic ketoacidosis, and that further deterioration starts once you start your treatment. So there are, and plus there is a possible effect of cerebral hypoperfusion and reperfusion injury. There was this case report which was published in 1991 in a child who had passed away from cerebral edema within onset of 2 hours from the start of therapy, thus questioning the role of fluids in the evolution of neurological injury in DK. These studies involving children with DK and rat models suggest similarities. That is, they noticed that cerebral hyperemia and vasogenic edema was present during treatment for diabetic ketoacidosis, whereas this study correlated apparent diffusion coefficient values with clinical and biochemical variables and concluded that cerebral edema is related more to cerebral hypoperfusion and that osmotic fluctuations during the treatment do not play a role. And this study indirectly detected cerebral hyperemia using NIRS during DK by measuring abnormal elevation in the regional oxygen saturations in the cerebrum and concluded that children had cerebral hyperemia as early as the 2nd hour of diabetic ketoacidosis, and no significant difference was observed in patients who received slower or rapid IV rehydration. Some other studies also showed various other contributory factors. That is, DK was associated with marked increases in cytokines and chemokines. It may contribute to brain injury by activating endothelia. We saw that earlier study which showed that rats with DK had elevated endothelial activation markers in serum. Then elevated levels of matrix metalloproteinase were also there, which could promote blood-brain barrier dysfunction. And they concluded that basically neurological injury occurring during DK was a culmination of several factors. It was not only due to hypoperfusion alone. That severe cerebral hypoperfusion was unlikely to be the primary cause or the only cause to cause brain injury in the absence of other contributing factors. All of these factors together had to come together. So should I continue towards the appraisal?
Yes, yeah.
Thank you, sir. So what did we find in this study? So the lowest rate of decline of Glasgow Coma Scale score, as they said, was in the 0.45 NS fast rehydration group. However, the p-value was non-significant. But the same group also had the history of the death of one patient. At the same time, the study has not really shown a difference in adverse effects of 0.9 NS versus 0.45 NS, or whether fast or slow regimen. So from this, we can conclude that 0.9 NS and 0.45 both are equally good as maintenance fluid in DK who present with GCS of 14 or 15. Neither is inferior. However, what we wanted to question was whether these results are robust enough. If we look at the internal validity, this study was one of the largest RCTs that I myself have read as well. It was multi-center across 13 centers, and the data was monitored so meticulously. It was designed, conducted, monitored well. The data was well captured, including deviations, validity of findings. Various committees were involved in it. Investigators have also reported analysis of intention to treat and per protocol methods. However, what we found a little jarring was that, for example, in the initial bolus which was given, how rapidly was it given? Was it given over 1 hour, 2 hours? It was not defined or monitored. Surprisingly, the hyponatremia data was not shown. What was the sodium levels during the treatment? And frankly, we have all admitted and treated patients with diabetic ketoacidosis, and we know that how their mental status is when they come with around a pH of 6.9 and 7.2. So we found it a little funny as how they could test memory and digit span tests in these children. Agreed that they were above 3 years, but it is a little difficult. Then what was the outcome in the subject with protocol violation? Those 115 patients who received fluids which were not protocolized, what was the outcome in them? Plus the loss to follow-up that we initially discussed, that almost above 80% we can understand, but the follow-up was basically 57 to 64%. In terms of memory and IQ, 30.1% dropped out before coming back for follow-up, and for digit span tests also 36 to 43% drop. Also coming to sample calculation, if we go to their initial protocol, so they started the study assuming that 15% of children who were treated with DK demonstrated mental status abnormalities, and estimated that in their study 10% would. However, in what this actually did not happen, only 39 or almost 2 to 4% deteriorated in the GCS during treatment. So is this study really powered enough to draw a conclusion regarding effect of fluid on the neurological status? Again, when we go through the consort diagram, we see that initially 2,848 were eligible, of which multiple numbers were ineligible due to reasons which we felt were not very challenging. These could have been overcome. So this was quite a lot of, we lost quite a lot of patience in this, and this could account for bias, as we had discussed earlier. And in the shortcomings, as we discussed, others that we discussed, protocol deviations we observed in 115 cases. Most kids had only mild to moderate decay. Hence, these children may not develop significant adversities related to the different fluid regimens. We have tested, they've tested memory function, short-term memory, contextual memory, IQ. But we could not have idea about how these parameters were in the children at baseline. So what we can conclude from this study is that regardless of what fluid regimen is there, the memory affection is similar across the 4 groups, but we cannot compare against a baseline. And they may have been better, they may have been worse prior to the decay itself. So in conclusion, in important findings, I'd just like to reiterate that the lowest rate of decline of GCS was seen in the 0.45 NS fast rehydration group, but the p-value was non-significant. But at the same time, there was also one death in this group. The study has shown no differences in adverse effects of 0.9 NS versus 0.45. So we can still conclude that 0.9 is as good as 0.45 to use as maintenance or rehydration fluid in diabetic ketoacidosis in children who present with GCS of 14 to 15. Going to another study, has any other study achieved what this Pecan study has achieved? So we go to a Dallas study, which was carried out in 2013, which basically assessed the rate of complications, particularly cerebral edema. It was a single center retrospective study in which they looked at 3,712 admissions with decay from 1999 to 2011. They used a 3-bag system. So they had 3 bags, total 2 bags were of rehydration fluids, and one had 10% and had an extra component of D10. And the third bag contained the insulin infusion. The fluids were administered at 2 to 2.5 times the maintenance fluid requirements, and the fluid content was kept approximately isotonic. They found 20 cases of cerebral edema, which comes to almost 0.5%. Most presented early, within 2 hours. And of the 20 patients, 10 CT scans showed moderate cerebral edema, and only 10 patients received treatment other than the routine decay management. There was one death. However, this child had a comorbid condition. She was a known case of sickle cell trait, and when they did a review, they found that the death had actually occurred due to intravascular sickling. In 2 cases, there were neurological sequelae, one of which I think the child had ADHD but is on atomoxetine for the same. The other child recovered fully. And basically what they concluded was that there were extremely low rates of death and disability from decay. So I think from this study, what our take is that 0.9 NS is as good as 0.45 NS, because considering that they found neurological injury in only 2 to 4% compared to an expected 10%, we are not sure if the study is strong enough to recommend fluid regimens and neurological status, the correlation between them. Thank you.
That's what
Can I
she
stop?
wanted to, yeah. What she wanted to say, that after toiling so much, they have found what they have found. While there is another observational study which was done over almost 12 or 30 years, 6,000 odd patients, and what they found, you have seen it. So my questions to all the experts is that, was this RCT necessary at all?
Yeah, Dr. Nupur,
Just to raise some controversial point, nothing else.
Ma'am, first of all, Dr. Nupur, a fantastic effort, I think, for a journal club. A couple of things which I had noted down along the way, you had already kind of brought it out, like like the GCS score, like in a sick child, to assess GCS, every hour, and to look at a GCS which fell by about 1 or 2 points is very difficult. But then, in the absence of any other alternate way to look at the primary outcome, I guess that was the best they had. The concluding slide, you mentioned about the kind of fluids, 0.45 versus 0.9, but the bigger interest that we all have, I'm sure, as people who treat DK, is the rate of administration. Your conclusion didn't have anything about the rate. So what is your take on the rate of administration? Would you go fast? Would you go slow? If you say fast, how fast? If you go slow, how slow? Then the others, I'll have a few more comments. Yeah. Based on the study out. Based on the study.
Just one thing which I want to add, that was, it was not just the slow versus rapid and low concentration versus high concentration, but there's one more thing. It was higher fluid versus lesser fluid, because the faster group ended up getting 10% dehydration correction and the slower group got 5%. So in fact, it was even higher versus lower fluids also.
Interestingly, sir, what happens is that if you look at the chart, I've been following this particular DK protocol, fluid management, for several years now. The so-called fast, they corrected 5% dehydration in 12 hours. So they planned for 10%, 5%, that they skewed the correction for the first 12 hours, was done a little faster. So they did 5% in 12 hours, and the remaining 5% they were proposing to do it over the next 24 hours. So it is about a 36-hour correction, and the slower was, of course, slower. But interestingly, like Dr. Vaman pointed out, that over several years since our residency, we were always following Milwaukee regime, which is perhaps one of the fastest correction. It's 8.5% dehydration in 24 hours time.
24
so, but of course, again, I guess for the purpose of trial, they chose both the extremes. They were trying to I don't think they went faster than Milwaukee. The slower was the conventional 48-hour correction. So the question to Dr. Nupur was, would you, based on the article, go for a 48-hour correction or a 24-hour correction, or you would say, based on this article, it makes no difference?
So based on the article, I feel it makes no difference.
All right, so you could go faster. That means you could, if a particular unit is wanting to correct over 24 hours, like Milwaukee does. Blindly does 8.5% correction for every child. Unfortunately, I think the biggest mistake we make in these kind of conditions is that one size does not fit all. So all these DKs that we see across the years, there are not too many of them, unfortunately. So they all come with different sets of dehydration. The best way would be that if you knew their pre-morbid weight, if you knew their pre-morbid before they fell sick, and the duration of illness, whether they were sick for 1 day, 2 days, 3 days before they came in, and that was the best way to correct the dehydration, but we don't have. So in fact, if you look at the BSPED guidelines, which came, the ISPAT guidelines came in 2018. BSPED came in 2020. And based on this study, they thought that it would be wise to go a little faster. Particularly in the sicker ones. but then there were so many comments on those BSPD recommendations. And the last is in 2021, the NICE guidelines. Again, I mean, both NICE and BSPD is both British, so they have kind of tried to go back on the so-called. They've drawn some negatives on the faster correction. So I guess there's no real answer. You have to probably treat each child as
their clinical presentation.
Different. Every child is going to be different. So that's one point. And interestingly, another comment, we could always draw something from the adult. I've always been fascinated. The adults always are liberal with fluids. They give an insulin bolus, which we are hesitant to. But again, like it happens with the sodium corrections and so on decay, that the pediatric decay seems to be different from the adult decay, but they have got around from not having so much of cerebral edema as we have. And any trial which looks at trying to look at the neurological outcomes, where the neurological problem itself is so less, it is less, cerebral edema is less than 1%. To plan a trial where the outcome is so rare an event is again possibly very difficult. So I guess in terms of trial, ma'am, it's a good trial, but whether I would change my practice based on that, that's a different question altogether.
Well, yeah, well said. BSPD1 protocol was really too less fluid. And now if you look at their amendment, it is exactly same as ISPAD protocol. There is a difference between BSPD, which is recently published, and ISPAD, which has been there for a while. So people have written many diabetic decay protocols over the years. Now, I remember in 19 in England, when we used to treat DKAs, we had a very simple protocol: 1/3, 1/3, 1/3. Calculate every child either as mild, moderate, or severe, 5, 7, or 10%, and the same fluid. You will be astonished to know there were pediatricians in England who would give isolate P along with insulin, but 3 parts: 1/3, 1/3, 1/3. So you calculated the fluid for 36 hours. First 1/3 you gave in 8 hours, next 1/3 in 12 hours, and remaining 1/3 in 16 hours, and made no difference whatsoever to the outcome. So I think there have been at least 10 decay protocols that I have lived with over the last 3 decades. And BSPD problems with, because it led to hypoglycemia much more commonly, and it took much longer for children to recover. But coming to this point, that is your journal club. We won't be discussing decay protocols today. Coming back to your journal club, I think, Dr. Nupur, you have done a wonderful job. I would go to the extent of saying that this is one of the finest presentations I have ever seen by, I'm not sure at what level of education or training you are, by any PhD lecturer for that matter. So kudos, very well done, extremely good analysis. And if you have not been helped by any of your seniors to come to this presentation, I think hats off to you. And if you have been helped by your seniors, I congratulate them also, because it is a very, very well analyzed paper. Yes, I entirely agree that based on this paper, I would be very reluctant to change my practice, because one point that you very clearly mentioned is that this protocol, this paper is only for mild or moderate decay. See, the real difficulty is with the severe ones, because they are the ones who are likely to have or require the real expertise of a pediatric intensivist in terms of the rate at which the sodium drops, correcting the sodium for the glucose. None of that has been mentioned. So that is definitely a big hole in that whole analysis, because complications, as we understood till now, is more related to the rate at which the osmolality changes, the rate at which the sodium drops, the rate at which the sugar drops, etc., etc. But I think a fine analysis, and I would give full marks to your effort and your team. I'm sure Dr. Madhu is also involved in this. And with that, I don't have much to contribute. I only wanted to share a couple of slides, mainly because we are having a journal club and a lot of PGs are more interested in very basic things. So if you permit me, I'll show 2 or 3 slides, if that is allowed by Dr. Madhu and the team.
Please.
Yeah.
Sir, another interesting thing was that when you look at the supplementary data from this article, and like it's our clinical experience, almost all these so-called mild and moderate, rather than like severe was excluded in this study as well. that they all become all right by about 14 to 18 hours. So
Yes.
whether you follow Milwaukee or any other regimen, we find that the children are up before you've hit the complete correction. So that's another beauty of the moderate and the mild one. Severe, of course, is a different game altogether.
Very true. Very true. So I just, for the interest of people who are listening, I just wanted to show this slide, is that what is the traditional hierarchy of evidence, or how do you actually grade studies? So this is from top to bottom. Top are the best ones. Systematic reviews and meta-analysis are considered to be the best evidence, followed by randomized control trials, followed by cohort, then case control studies, then cross-sectional surveys, then single case reports, and last is expert opinion. So if you now look at this pyramid, this is how the level of evidence is graded. So whenever nowadays you look at a guideline being written, after every important statement, there is a yellow, and that is graded. So this is how you do it: background information, expert opinion, case control, cohort studies, RCTs, critically appraised individual, critically appraised topics, evidence synthesis, and systematic review. So people, whenever they are trying to read a paper, they should be aware as to what type of paper they are reading. So here, what you have is a randomized control trial. So RCTs are some of the most powerful among studies. And so are the systematic Cochrane database, for instance. And then there are 2 or 3 more other slides that I had, which may help people to understand some very basic facts of statistics. Like, people are going to do their thesis now. So try to understand these important things. What are the type of variables that you're studying? What is the type of data you're studying? Is your data parametric or non-parametric? So variables can be independent, dependent, categorical, continuous. Data types are nominal, ordinal, interval, and ratios. And types of data, parametric, non-parametric, that I think we spoke about. Then why do you want to read papers? As we said, that you want to improve the clinical practice, but it has to be evidence-based. Because it has to be evidence-based, you read papers and you draw conclusions. And I think that was mainly what I wanted to say. There are some more slides, but they may not be relevant because I think people have become better and better at browsing the internet now. So, but important thing is, what database are you reading? See, previously there used to be CD-ROMs. They are gone now. But online databases are very useful. So you should make use of the MED, which is the National Library of Medicine. You can use Google Scholar. You can use Cochrane. You can use many other databases. But make sure that you understand the search keys. So whenever you enter a phrase in the search, make use of and or operators. So if you use and operator to search for an item, then you are searching both phases. You have to put that as capital and. If you put capital or, then both will be picked up. If you put a not, say for example, you say diabetic ketoacidosis and not sodium concentration, then studies without that will not come up. And also, when you get the journal, look at the dates, sort it by the date. More presented first, because a lot of recent articles actually review all the previous articles which have been studied. So with that little information I wanted to pass on, I would like to thank you all for allowing me to share my experience here. And thank you very much.
Aman, there is one question from Dr. Geeta Karambelkar. So anyone of you can please answer. I'll just read out the question. Reference studies, how many years back can be taken as standard for implementation?
I don't think there's a number on it, because just to answer that, and it's a pride for an Indian scientist. I don't know, many of you may not know this gentleman called Mahanalo. Mahanalo was the first statistician of India. He was on the Planning Commission of India. But Mahanalo was such a great statistician that there is a distance called as Mahanalo distance, which goes by this gentleman's name. And the distance is to decide whether whatever you have newly designed is actually matching with what has been published so far. So if I produce IAP growth charts then I need to know what is the Mahanalo distance between what is idealized and the newer centiles of the IAP growth charts. This Mahanalo distance was in 1933, and even 2021 paper would first give the reference of Mahanalo. So, Dr. Geeta, I don't think if you can produce something of that caliber, then there is no time limit for that.
Anyone else? Sachin, you want to say something?
So again, yeah, it was a fantastic presentation. And like there are two aspects when you present a journal club. Yeah. One is like how statistically sound is the paper. That's one thing. And the other thing is like clinically, does it make sense? And we all discussed like about the clinical aspects of it. And all those clinical aspects, the shortcomings, like what we see in usual practice, because they have not measured effective osmolality, which would be doing without osmolality, we wouldn't be chasing the fluids. So a couple of clinical aspects on which people have cast their doubts. But I would have liked to listen more to as to the statistical aspects, like whether the study was internally valid. And I would have like gone a little bit, I would have liked to look at the risk of bias table and whether the statistical methods were appropriate, which you already have commented. But I would have loved to see the risk of bias table especially. And I know this is a low risk of bias study, but just for the sake of PGs, it would have helped them. And the other thing is like, I would have also commented on the external validity of the study. And especially when it came to the discussion part, when you are comparing like a retrospective study with a randomized control trial, it's like comparing apples with oranges. You cannot do that. You cannot say this was a large retrospective study and I will rely on the reports. Like as Vaman pointed out, we are going to throw it in the bin if we have a RCT. So let us be clear on that. So if when you are discussing, especially when you present a RCT and you are going to, the corresponding evidence has to be from equivalent RCTs so that it makes easy for clinicians to take an informed decision. So those were a couple of points that I wanted to make out. Otherwise, it was fantastic, like nice presentation.
Thank you, sir.
Vijay?
I agree. I think the slides were excellent. Very well done. Very well done.
Okay. Sanjay, are you there? So we can.
Yes, I'm here. So I think it was an excellent first journal club from IAP Pune. Great presentation by Dr. Nupur. Excellent interaction and many inputs from all our faculty. So I'd like to thank Dr. Vaman Khadilkar sir, Dr. Sachin Shah sir, Dr. Vijay Kalrao sir, and Dr. B.M. John sir for chipping in with very important inputs which have added a lot to our knowledge. And we hope to keep on seeing you for further journal clubs as well. Thank you, Nupur, for an excellent presentation. Dr. Rajesh Kulkarni, Dr. Oti madam, thank you for coordinating the whole exercise. And I'm sure we'll have further journal clubs with more inputs from all of you. So thanks a lot.
Can I say something, please?
Such a great initiative. Please. Such a great initiative.
This was a very difficult paper for me to analyze. So it's frankly, madam has done all the work. I have basically done nothing. But she has explained to me how the study works, and she has gone through so many references and told me we can look at these studies as well as those. So frankly, sir, all the credit should go to madam, sir.
No. This is you have taken a lot of efforts. Thank you so much.
Your credit is because you did not deny, you accepted the challenge. So that's Khadilkar sir wanted to say something.
Yeah, Sanjay, I want to congratulate you and Pune IAP for taking this on.
Thank you, sir.
I think this is such a wonderful thing because otherwise PGs really, I told you that kissa about Fokat ka magaj mari, so that they shouldn't really be looking at it that way. So great initiative. Please keep it up. I think we all learn through the Zoom platform. It has really become easy. It's absolutely so much. It's very enriching for me to learn from all of you, and thank you very much for the opportunity. Thank you.
Thank you, sir. Thank you.
Thank you all.
Thank you, ma'am. Thank you.
Bye.
Thank you. Bye all. I think we can stop the meeting.